See my screen? Okay, great. Now if I can get it to work, that would be good. Okay, so thanks again for attending. I'm really excited for the discussions that we'll have today. I just want to introduce myself first. I'm Jenny Rosselli. I'm a clinical associate professor with the School of Pharmacy at Southern Illinois University, Edwardsville. And for the past 11 years, I've had a practice site with SIHF Healthcare. It's a federally qualified health center that has a network of about 30 community health centers that are spread out in about 12 different counties in southwestern and central Illinois. And I split time between 2 of those health centers providing diabetes care and cardiometabolic services. And so I'll let Andy introduce himself.
Thanks, Jenny. I'm Andy Schmelz, and I'm an assistant professor of pharmacy practice at Butler University here in Indianapolis, Indiana. I'm also a clinical pharmacy specialist in ambulatory care at Eskenazi Health. I'm specifically at the Eskenazi Health Center Westside Clinic. And Eskenazi is our safety net health system here in Marion County, the county where Indianapolis is. And we have 11 outpatient sites that are all federally qualified. I've worked in this setting for about 4.5 years total. So 2 years in postgraduate training and then 2.5 years in my current position. But I've been an ambulatory pharmacist for over 10 years.
All right, thanks, Andy. So just a brief overview of the agenda that we put together for today. What we want to promote is a lot of discussion. We saw with the registration that there's several people on the meeting that have a lot of experience at FQHCs, and what better to share our different practice experiences, what's worked, what hasn't, to maybe go into some untapped areas that we weren't personally aware of, and promote the practice of pharmacy and FQHCs. So we'll start with an overview of FQHCs because there are some folks on the call that don't have practice experience in the setting or maybe new to the setting. And then we'll go into the breakout session 1, discuss some practice opportunities and what might be some of those initial steps to start planning for implementation of those opportunities. Then we'll come back to the main session, debrief, share some of those key points that your group talked about. And then Andy will talk about some billing and cost savings opportunities that'll lead us into breakout session number 2, where we'll focus on implementing pharmacy services and how to sustain those services as well. And then we'll wrap up with a final debriefing with the entire group in the main Zoom room. So with that, let's just briefly talk about federally qualified health centers and how they are different than other healthcare settings in that they provide mainly primary care services to everyone of all ages, regardless of their ability to pay. It's really an outreach or a safety net organization or healthcare setting to reach out to patients who do not otherwise have easy access to healthcare services. And FQHCs are generally known as community health centers. However, FQHCs can provide these services to other locations, such as public housing centers, outpatient health programs that are operated by tribal organizations. They may provide services in homeless centers, or reach out to migrants through mobile health services as well. We've seen in the past several years that many FQHCs are branching out to provide other services besides primary care that would include some specialty areas such as HIV or hepatitis management, providing behavioral and mental health services, addiction treatment and recovery services. So these community health centers or other locations where FQHCs are providing their services, it's providing more that holistic approach to patient care because again, the patients they're serving would not otherwise have access to these specialized services. And so the requirements for an FQHC, which is managed by HRSA, they must offer a way for patients to have access to these low-cost health services, and that's done through what's known as a sliding fee scale. And this will be slightly different from FQHC to FQHC because that will be voted on by the governing board of directors for that FQHC organization. So for example, when it's all based on the patient's income and family size. And so for someone who may be of homeless status and does not have any income, they may have a fee of $10 for each visit, and that would cover every service that's provided on that day. Someone that has income but is still considered low income, they may have a $15 visit fee to cover all the services provided on that day. FQHCs, again, are required to provide comprehensive healthcare services and also to have quality assurance programs built in and report out on the various quality measures and metrics on an annual basis. So the way FQHCs can sustain these services at a low cost is by operational grants under Section 330 of the Public Health Service Act and through Medicaid revenues. The bulk of their funding source is Medicaid revenues, followed by the operational grants from the federal government. They also will operate through other funding sources that may be local, state, like partnering with the various state departments of public health, or other types of national and federal programs that offer funding. What we also need to note that's very different about FQHCs from other healthcare settings is the payment structure is drastically different. So Medicaid and Medicare payments are provided to FQHCs based on the prospective payment system, or PPS. And that's where the FQHC is given, they're paid based on a per visit rate for the cost of the services. And so for that rate visit, it covers their medical services provided, any supplies that are used. So for example, if we do a point of care A1C with the primary care visit, all of that is included under that single rate that the FQHC gets for providing services to the patient on that day. And so the other things that are sometimes different that we have to consider with FQHCs is on their billing structure and who is listed by CMS as a FQHC practitioner that can be billed, or their services are billable. And those include physicians, nurse practitioners, and physician assistants. Pharmacists are now considered as auxiliary staff. And so one example of where the auxiliary staff or pharmacists can fit in to provide services is through transitional care management, chronic care management, behavioral health integration. Andy's going to talk about some of this a little bit later. But with this type of status, we're able to provide these services, and there is some billing mechanisms that are available, and we can do that with general supervision, not direct supervision. So that does provide some extra flexibilities for us to provide these services. Oops, I'm sorry. Okay, the other component that FQHCs have the availability to offer services for is the 340B program. And this is through the Public Health Services Act, Section 340B. So that's where the name comes from. And this is where the manufacturers who participate in the Medicaid programs for the state agree to provide the outpatient medications for these entities. And FQHCs are considered eligible for 340B programming, and they provide these medications at very reduced cost. So the lower cost medications are then available to the patients of the 340B entity, enter in the FQHC. So any patient who is seen by providers in the FQHC, if those prescriptions are written by those practitioners, then those patients are eligible to receive the medications through the 340B program at a lower cost. And the FQHCs may have their own in-house pharmacies, or they may contract out to provide for other pharmacies to provide the 340B program. All right, so let's talk about getting started with being a pharmacist, providing services within an FQHC. And the way to get started is going to look very different from organization to organization, and it may look different even within the same organization, from person to person or from service to service. So that's where I think some of the discussion today can be helpful to find out like where you started, if you were successful in being embedded in the FQHC or providing services for the FQHC. But one place to always think about is, what are the organizational needs? What kind of service gaps are there? What do they need help with in providing the best care to their patients? And so, for example, with my FQHC, it was identified that there was high prevalence of diabetes in the area and the patients that they serve. And so that need was identified, and the organization partnered with the School of Pharmacy to apply for a HRSA grant in order to promote the pharmacist position to begin providing collaborative pharmacist physician care for diabetes management. Another way to look at organizational needs is their quality measures of interest. And so going to the diabetes example, like you can see a lot of these organizations will report out the percentage of patients who have A1Cs above 9 or below 9%, maybe looking at blood pressure, things like that, and how to improve upon those if they need to, because if they can improve on some of those quality metrics, that can increase the amount of reimbursement that they receive from their payers. Meeting with different stakeholders within the FQHC is critical, and the order of how this is done can vary as well. So, thinking about your physician partners who can be the champion for you, who's willing to partner with you and promote the service and meet with the necessary administrators to make it happen. The medical officers are another key person to meet with, who are usually at the table for making decisions for new clinical services. The support staff can be really important on this, like nurses can identify some of the areas that those providers may be having challenges with that they could use a pharmacist support, and then you go and speak with that physician or practitioner about that. You can also start from the top down too, finding out what administration may need, or through the grant managers. What are they working on? What opportunities are there for funding to stimulate opportunities to provide services that are pharmacist driven? And so with that, I want us to get into the first breakout session. Megan, did you have an opportunity to divide people up?
Yes, I am finalizing those right now. I'm going to go ahead and pause the recording, and then I will open those rooms for everyone here in just a second.
All right. I'm just going to call on a couple of the facilitators. Let's start with Neha. What did your group talk about?
Hi. So we had different people that have had quite great experience in the FQHCs and have pretty established practices. So we talked about the different collaborative practice acts that and agreements that they have within their FQHCs. And so everything from diabetes to cardiometabolic to osteoporosis. And so we had the different conversations around how some have individual CPAs for individual disease states. And then one person was saying she actually has one, which was much more comprehensive and allows kind of to have less limits within it and touch upon a lot more things at once. So I thought that was really interesting for those of us that are going to be starting or maybe changing our CPAs within our FQHCs.
Okay. Yeah, that'd be a good place to start. All right. And then as far as, did you get into any discussion about like where you would go next with that? Like, okay, we can do osteoporosis management. Now, who do we talk to about that?
No, maybe we can talk about that. We were just starting to talk about how some of these other unique services like osteoporosis is really important, especially in our underserved population, but that's where we got kicked out. So we'll come back to that and hopefully be able to talk about that on our way back.
All right, excellent. How about Chris Lynch? How was your group's discussion going?
We had a good discussion and we went right up to the last second as well. But we have a diverse group of experiences with a grant writer, a director of pharmacy, as some providers that have worked for several years, and then some newer providers. One of the things that was interesting to me was Courtney's take on coming at it from a traditional pharmacy, where primarily dispensing, transitioning into more direct patient care out of the box of the pharmacy types of things. And I think that that's an interesting model, which a lot of people are probably in. Then we also spoke about disease state management, as well as the importance of integrating the idea of annual wellness visits. And I think that's probably where we will pick up when we get back into our breakout group.
Okay. All right. And with coming from the community pharmacy side, is that like if there's an in-house pharmacy and then being able to collaborate as a pharmacist that may be dispensing, but also working into a more clinical role, is that model you're talking about?
Yeah, that's correct. Exactly. Yep.
Okay. All right. And
And
perhaps
we also had people that were supported by a university, as well as people that were completely funded by an FQHC. And I think those are two really interesting models that are kind of completely different from each other from a financial point of view.
okay. All right. And then how about Kelly Gable? How was your group?
Yes, hi. Our group had a wealth of wisdom as well and experience. And so we had folks from Baltimore. Actually, there were 3, and there are 5 FQHC sites that they were working through and on the Eastern Shore. I heard a variety of different types of activities, from STI clinic to diabetes manager program that was just established, and also opportunities for HIV, hepatitis C work, and anticoagulation as well from someone in Milwaukee. Lots of opportunities to work with local homeless communities. However, without extra funding or expansion, it makes it challenging. I heard a mixture of folks that are working through funding through academia, and then also someone just got hired on in Hannibal, Missouri, as the FQHC sought out a pharmacist. So we were about to talk a little bit more about that. And also billing was the primary struggle for all of us, just finding adequate ways to bill. To one group actually acquiring grant funding that acquired a nutritionist, and the billing from the nutritionist actually helps with the pharmacy funding. So that was unique. And I think we were about to talk more about that too. So lots of good stuff.
Okay, awesome. All right, so I think that's a good lead in for Andy to take over now and talk about some of those opportunities for billing and sustainability. And so that means when we come back from that second breakout session, that like Chris Herndon and Eddie, we're gonna hear from your groups after that, okay? Just so you have the heads up now.
All right. So I wasn't intending to talk about all of the different potential mechanisms that exist for funding a pharmacist in FQHC, because there are many, but I wanted to hit some of the bigger opportunities for us and some of the common things I think that I see people doing. So we're going to talk about a handful of direct billing opportunities first, and then talk about some other ways that pharmacists may be funded indirectly. And to be honest, many of us utilize multiple of these tools to successfully fund a pharmacist. So don't think that you need to choose one, and that would preclude you from doing the other. Sometimes it takes a little bit of many of these to sustain an FTE in the clinic. So the first thing that I wanted to talk about was the shared visit model, or you may also hear that called split shared. So under this type of model, this is where patients are actually seen by both a pharmacist and another recognized provider during that same clinical encounter. The advantage of doing that is that other recognized provider is able to bill for the service. And the way that this works financially is that any services that are provided in the clinic that day during the encounter can be considered when the provider determines the billing level. So for the maybe fewer number of non-Medicaid, Medicare covered patients, they may be able to bill their visits at a higher level and receive higher levels of reimbursement based on that. However, remember back in the beginning when Jenny talked about how under Medicare and Medicaid, those visits are paid under the TPS, and in those cases, all of the FQHC visits that occur in the clinic are billed at the same level, so there's not differences there. However, there is an opportunity to I'll still use this model, because if the pharmacist is providing the bulk of the services and the physician only spends up to 5 minutes finishing the encounter with the patient and then doing their documentation and billing, then that provider, we can really work to optimize their schedule, and they can potentially see a greater number of patients during a clinic session. And it really doesn't take a lot of extra appointments during a clinic session for it to be worth the physician's time to do it. So again, I think the main barrier for using this type of model is making sure that the visits are well coordinated, since a patient would be seeing multiple providers. There has to be good communication between the pharmacist and the provider, given that they're kind of following after one another in quick succession with the patient. And the types of services that are well supported by doing this model are really disease management, so any disease management, also the annual wellness visits that we'll talk about in just a second, and then transitional care management visits also work well in this type of model. All right, so getting into annual wellness visits. So pharmacists provide these in other outpatient settings as well, not just in the FQHC, but we have an opportunity to do those in the FQHC as well. So in case you're not familiar with these, they're yearly appointments that a provider conducts with a patient, in which they will create and then subsequently update a personalized prevention plan. So that includes like screening tests that patients need on a regular basis. It also includes vaccines. It includes assessments like looking at their risk for depression or other things like that. And I've listed the billing codes here for these. And don't be intimidated by those if you're not doing a lot of this work currently. This is more for informational purposes. But for the wellness visit, it kind of comes in 3 different flavors. This first one is called a welcome to Medicare visit that a patient is eligible for during the first year that they have Medicare. And then after that, they get annual wellness visits, and those are differentiated by their first wellness visit and then each one that's subsequently done after that. Now, in the FQHC setting, again, we need to have a provider assist us so that we can actually bill for providing these visits, which is not the case outside of the FQHC setting. So they do, in other words, they have to occur during another billable encounter from the provider. So the provider needs to see the patient as they would for a normal office visit. And then this wellness visit is something additional that's added on afterwards. However, it can occur before the physician sees the appointment. But, all right, and then as far as the revenue opportunity, because we bill Medicare, we get paid on this special fee schedule that's not what the normal outpatient physicians use. Our PPS rate is actually adjusted up by, just over a third to account for that extra work that the pharmacist would spend conducting annual wellness visits. Care management services are also opportunities for pharmacists to get paid for services. What these are really additional revenue opportunity for the offices that provide care management beyond what occurs in a normal office visit. And it's really based on time that ancillary staff or others spend coordinating care for patients. The billing codes are divided based on how complex the patient is. So there's a number of criteria that a provider or practitioner, an FQHC practitioner, needs to assess to determine if they benefit or can enroll in this. And then based on how many of those criteria they meet, they fall into either non-complex or complex. And then again, the billing is based on time that the clinic staff spends doing things around a care plan that's structured for that's created for that patient. That time doesn't have to be consecutive. So I've seen systems where different types of providers may keep track on spreadsheets, like how much time they're spending doing certain things for a particular patient. That has to do, again, with that managing that care plan. The care plan being like all the things that patient needs to be doing and making sure that stays revised and it's monitored. So really a couple of other things I wanted to point out about these. So they do require an initial visit with an FQHC practitioner within a year of the first time they've done it. So this doesn't replace like regular visits with a provider in the office. As I said, only FQHC practitioners can identify who meets those criteria, and then a patient consent and their care plan has to be documented in the chart, but they don't have to like sign a consent form that's scanned in. They can just get verbal consent. Also under care management service, we see that transitional care management services kind of fall under that bucket as well. Those are essentially services that are provided kind of in the time between a hospitalization and then a subsequent visit with a provider to follow up from that hospitalization. So they have to hit 3 criteria, including an interaction within 2 days of discharge. Often I've seen that be a phone call with a clinic staff member. There has to be additional non-face-to-face services provided, and that can include things like just reviewing tests and also helping with scheduling to make sure that that subsequent visit happens in a timely manner. And then again, that face-to-face visit after that hospitalization has to occur within 14 days if they are a moderate complexity patient, or 7 days if it's a highly complex patient. As far as the revenue opportunity, those visits are billed at the same level and they get reimbursed at the same level as a regular FQHC visit. So there's additional like opportunity, I guess, to justify the pharmacist providing this transitional care service based on the revenue that they're helping generate. I heard many people talk about doing diabetes self-management education and support in the breakout room that I was in. So again, we pharmacists are able to provide these outside the FQHC setting as well. But what these are programs that are accredited by either the American Diabetes Association or the Association of Diabetes Care and Education Specialists. And the program gets accredited and then allowed to bill for providing education services and support to individual patients. The billing code that I have here is for an individual patient, and it's billed in increments of 30 minutes. So each 30 minutes that the patient gets, an additional code would be billed. One thing that's different in the FQHC setting, as far as diabetes education goes, is that we are only able to bill for individual services. So we are not able to bill for group diabetes education at this time. We can provide it, we just will not get reimbursed for it if it's done. So pharmacists who are certified as DS, MES, or also medical nutrition support practitioners are who's eligible for billing in these programs, and you can bill either under the program or a pharmacy's NPI number. And then Medicare does limit how many of these types of visits a patient can have. So they limit the coverage of DS and MES to 10 hours in the first year, and then 2 hours on subsequent years.
Hey, Andy, can you close the reminder box?
Thank you.
Yep. Thank you.
Not looking at that screen. Okay. All right. So the next opportunity I wanted to discuss for those of you who work in clinics that have a pharmacy, I feel affiliated with you or attached to you, that you have control over finances and clinical services and that type of thing, are MTM services. So these are services that can be provided again in other pharmacies, whether they're attached to a clinic or not. MTM was originally established for the Medicare Part D program and subsequently has been kind of taken up by several state Medicaid programs as well as other third-party payers. There's 3 different codes I have for billing. Really, they have to do with whether or not that you're seeing a patient for MTM services the first time or if it's a subsequent time. And those 2 codes cover the first 15 minutes of the service that's provided. And then there's an add-on code for each additional 15 minutes that's provided to the patient after that. Again, usually these are focused on through like an outpatient pharmacy, and that's historically where they have occurred. There are some plans that have contracted with like companies like Outcomes MTM, for example, that will allow these services to be provided in an outpatient doctor's office, even if there's not a pharmacy affiliated with them. However, billing through that platform will limit the number of like different plans that you're able to do that for. All right, and then I'm going to move on and talk about a few indirect ways that we can justify pharmacists financially in the FQHC setting. The first that I wanted to discuss was performance-based initiatives. That includes ACOs, other types of shared risk arrangements, and that can be true whether or not you have the PCMH designation, but sometimes having that patient-centered medical home accreditation or certification will be the thing that allows your clinic to participate in some of these models. So really the pharmacists can kind of indirectly justify that their salaries really by helping improve quality measures. So that means that a lot of services that are structured around meeting quality measures, like diabetes, for example, if the pharmacist is working to help improve those numbers, then they may negotiate with the clinic to get some of that money specifically for the pharmacist's salary. Also, cost statement adjustments. So the way that the PPS rate for an individual FQHC is calculated is based on the cost that that FQHC spent over the past year. So technically, an FQHC could list the pharmacist's salary on their cost statement as the cost of doing business or the cost of providing the care that they do. And then that may influence the rate that that clinic will receive for all of their FQHC visits for the subsequent year. Also, we talked about 340B programs. So again, FQHCs that have affiliated or attached pharmacies that get 340B pricing, that savings slash revenue that is created because you're buying cheaper drugs and selling them, especially if you're still billing insurance, can create high margins that can be used to justify lots of clinical services that can be either run out of the pharmacy or used to justify pharmacists that are embedded in the clinics. And then I heard many people talk about partnering with colleges of pharmacy. And I've seen these work in a couple of different ways. I've seen them where the College of Pharmacy pays the pharmacist salary completely, and then, okay, you don't have to worry about billing. But I feel like what happens more and more nowadays is that they're sharing the cost of pharmacists. So then the FQHC isn't going to be responsible for covering that pharmacist's whole salary, but they can use some of these other mechanisms to help kind of piece together enough money and justification to cover the pharmacist. All right, and with that, we are going to head into our second round of breakout sessions.